I think these two things go hand in hand. Robotics, AI, automation. What Mr. Nadella said, that humans and computers will work together, not against one another. That is being seen today. Though yesterday was the first robot suicide. A robot committed suicide in Korea. This was a carer robot in a factory or a mall or something. So that has also happened. So we are looking at a certain different kind of future. But we will work together, though we can see still only a short distance ahead, but that plenty needs to be done. From Alan Turing, the man who originated what we know today as artificial intelligence. And a man whom I admire a lot is Pedro Domingo. He said that the God of Genesis himself is a programmer. Language, not manipulation, is his tool of creation. Words become worlds. Today, sitting on the couch with your laptop, as Vaibhav so eloquently demonstrated some time ago on those two cases, you too can be a god. Imagine a universe and make it real. The laws of physics are optional. This was written more than 10 years ago, but it is still a reality. So, we all know about the history of AI. Started with Turing. He made something called a child program, and then there was something called the Turing test. And John McCarthy is actually credited with, originating this word in the year 1957. Over the evolutionary cycle tells you about reactive machines that learn from data and react to changes in an intelligent world. That is what we call reactive machines. Then you have limited memory machines. You teach them something, they will respond to what they have been taught. Machines with a theory of mind can understand underlying behaviors and are capable of understanding and reacting to complex scenarios, including emotion. We are getting there. Self aware machines are the highest in the rung, which seems to hold a sense of purpose and can have opinion and cognitive biases. You could say generative AI is one of those, but we still are far from realizing a self aware machine. So, anything that makes the machine intelligent and capable of doing a task that can be done by humans, that kind of a program is what is artificial intelligence, and it contains heuristics, automatic learning, computer vision, NLP, intelligent agents, and all of that. And if you look at it in the context of orthopedics, you will see that there are a lot of things around here. You have machine learning, natural language processing, expert system, computer vision, speech to text, text to speech, automated planning, robotics. Everything is bucketed under the umbrella term of artificial intelligence. Though we use AI and ML together, machine learning is a subset of artificial intelligence. And I like to call it as augmented intelligence. Most of the AI that we see today is weak AI, which is task based and narrower. You train it to do certain things. So it is called narrow AI. They are programs that behave as if they are thinking. They are not thinking. Whereas strong AI is that which actually thinks, reasons, and takes action. We all know that it doesn't exist, and if it does exist, it is under wraps. And the basic building block of AI is an algorithm. It may be just a line of code or a few lines of code. It's an instruction given to the computer which would lead to a desired output. It may be a sequence of algorithms, it may be one algorithm. So, this is the basic building block. That's what an algorithm is. And whenever a task is executed, it is executed by a number of algorithms working in tandem. Clearly, you need to distinguish tasks. There is a learning task and there is an execution task. That is a performance component. So, the functional aspect of an AI program would have a learning component and a performance component. The learning component is what it learns, inputs, assimilates data, creates some kind of a classification, and then when you put a query to it, it gives you an output, that is the performance component. Machine learning is a set of techniques to enable AI. So there are a number of synonyms of it. That is statistical modeling, data mining, knowledge discovery, predictive analytics, and so on and so forth. Some of the common types are supervised learning. Supervised learning is you have a set of data, you label it, you annotate it. Say you have got hip X-rays, you annotate femoral head, femur greater trochanter, lesser trochanter, shaft of femur, AS, anterior superior iliac spine, and so on and so forth. Give a whole set of X-rays, make the algorithm learn it, and then build a model on it. And then when you give an output to it, it will give you, will give an input to it, querying it, it will give you a output based on what it has learned. So it was not doing any learning on its own. Whereas in unsupervised learning, you let an algorithm loose upon the data. It will pick up parameters, it will pick up features, it will classify them, it will organize them, and then it will give you an output on the query that you give. This is absolutely unsupervised learning. There is no training set here. Whereas in semi-supervised learning, you have a set of data which is partially annotated, and then you put it across to the algorithm is put to work on it, on that data which is semi partially annotated, and depending on whether it is right or wrong, an input is provided to that algorithm, to that model, and that's how it learns. So it's semi supervised, and so there is a lot of overlap between these. But what's most common that you learn today is deep learning, which is layered and complex arithmetic model. There is an input layer, and then there are multiple layers underneath it, like a sandwich layer, and then there is an output layer. So you have these recurrent neural networks and convolutional neural networks, some of the common ones which are used, and they are very useful, especially when you have multimodal data like EMR data, EHR data, image data, all of that, or say microphone signals, audio data, sensor signals from your watches. All of these are much better, used with this. So typical machine learning pipeline has a pre-processing phase where the data is cleaned, it is pre-processed, it is prepared using special techniques, and then it is put into the model or the kind of machine learning method which you want to use. Once this model is ready, then there is a test data set which is used to validate that model, and there are parameters to validate that. Once that is done, then only it can be deployed out in the real world. So some of these features that they actually look for is sensitivity. For example, if you give a set of images, the number of cats actually recognized as cats. So that is sensitivity. Specificity. Now, for example, the number of dogs incorrectly identified as cats in that data set. So specificity, that is one thing. Then there is an F score, which is a harmonic mean of sensitivity and specificity, usually between 0 and 1. And then area under curve or receiver operating curve, another area which helps you to understand how well the algorithm can measure between classes. So when you read papers on AI and all that, you will find some of these terms coming into play. Some of the metrics that decide the pros and cons of using AI in healthcare are regulatory. Today we are coming to combination devices which have software in them. So the concept of software as a medical device and software in a medical device, both of these are coming under heavy scrutiny, and both in Europe and in the FDA there is a lot of discussion. Ethical and medico legal questions. If you make a decision using AI, who takes responsibility? Then there is distributional shift, black box. You don't know what the hell is happening inside the model. You can't trace it. So there is something called explainable AI now, which we can use to overcome that. Lack of appropriate data, GIGO, garbage in, garbage out. Bad data inputs, bad labeling, bad output. Clear. So it is ultimately a machine. It's not a human being. Inappropriate sampling. Geographical underrepresentation. A data made in China need not be applicable, that model need not be applicable to India. So that kind of geographical problems, overfitting, and most biggest problem is to how to generalize a model to a global outlook. Can you use a model which is used to identify a certain fracture? It will identify only that fracture. It won't identify all fractures. So it becomes very difficult to generalize. So those are problems which we are looking at, but some of the areas where it's actually working is in the administration, clinical decision support systems, patient monitoring, healthcare interventions, and this entire evolution of digital care delivery is being facilitated by AI. Whether you have care management, prevention, investigation, self monitoring, diagnosis, even treatment, where your robotics and navigation and everything comes in, and your predictive analytics come in. So all of these are being facilitated by AI. In orthopedics, these are some of the areas of research which are happening. A lot of it is on imaging, a lot of it is on risk prediction and prediction of outcomes, and also on improving surgical techniques and improving imaging techniques. So, from the diagnosis side, there are a lot of work like fracture recognition, meniscal damage, arthroplasty, implant loosening. Surgical training is an area where it's coming in. Also in applications like AR and VR. In arthroplasty, right from pre-operative planning, robotics, implant design, predictive analytics, risk assessment, and post-op follow-ups, AI can play a role. And there's a lot of literature that is coming out. They are talking about everything from value-based care to even predicting which patient will overstay and what payment model will be applicable to that particular patient. To that extent, models are being developed, but they are developed in one particular hospital. Will it be applicable to another hospital? We don't know. So, and this publication has been on a rise. When we started writing our article on AI and ML for IGO, there was not much in the orthopedic literature. Now, if I hit a search, it hits at least 6 digits. So there is a lot coming out in the literature, and most of it is repetitive, but it is still there, and you should do it. Broadly in orthopedics, you have imaging based applications, adverse event prediction, hospital and administrative work, for example, pre filling of a data of a discharge sheet. And so that makes that cut work easier. Surgical planning and surgical performance, you guys are know very well how AI is helping you, how it is giving you that real time view. And you still haven't seen the power of AI. There's still more to come. There's a lot more to come. In the preoperative area, the most common thing is diagnosis of OA. You'll say, what's the use? But in large population models, there are in health registries. This comes in useful. So there is also some research on prediction of whether TKR will be required. AAOS has a best practice guideline and an ML based algorithm to standardize patient selection in TKR. So that the American Academy actually has it up on their site, so you can have a look at that. Size prediction, implant identification, robotic, whatever you're seeing here in robotics is a prime example of how you can select it. And plus, in the revision scenario, many of us keep asking in groups, which implant is this, which implant is this. At least you can come down to a manufacturer. So that is happening. Some work even I am doing on that. Pre-optimization, prediction of length of stay, preoperative planning and templating. For example, one work we did was automated landmarking. So you put in, say, a spine X-ray, push a button, marks all the levels, marks all the significant landmarks automatically, and then you can proceed with your planning. Similarly, maybe for a hip X-ray, automatically both the teardrops are marked. Your femoral head is marked, femoral head center is marked, the transition line, teardrop line, everything is marked, and then all you have to do is template. So that we have also done that kind of work also. That a lot of work is going on that. It sounds simple, it is not. It's not simple at all. Intraoperative image-free procedures, mixed reality, augmented reality, ligament balancing, etc. These are some of the areas which I will not cover in detail, but I'm just taking through. 10 minutes for AI is like covering Rockwood in 10 minutes. so, so I can't do that. So post-operatively, of course, now we are using a lot of wearables. I use an Apple Watch, you use a smartwatch. These are being used for monitoring patient. Used the Apple Watch for shoulder range of motion. We've used the Apple Watch. We've used a standard IMU for shoulder range of motion, which we have published. So This is important so that you can pick up the right patient who is not going to do well and who is not likely to do well. This is very interesting image, very important image coming from Batalier in Arthroplasty 2022, which shows the flow of data. Data is the new currency. All of this data is going to go somewhere, and you have to utilize this data, and that's where our artificial intelligence based methods are going to come in. It's going to make your surgery smoother, faster, and it's going to be your intelligent assistant. But data sources are from all of these. So these were the areas of research, even prediction of early revision, value metrics, patient specific payment models, component size, stay and cost, grading of osteoarthritis, detection of knee implants. They can detect between UKA and TKA. These are research, but I'm not saying that it is useful. Automated sizing and loosening. In trauma fracture recognition, we've done some work on ACL tear and meniscal tear recognition. So all of these on the spinal levels, prediction of complications following spinal surgery, selection of patients in spinal surgery, and of course in oncology it is well known. It is almost of you can predict whether you should do any surgery at all or not. So prediction of survival is one of the areas where it is done. Some of the new kits on the block, which use AI as their backbone, is augmented and surgical reality. The one on the top is Arvis, which has been recently approved for hip. It is already in use for the knee from Innovis. One below is Pixie. This one is, I think, being bought by Merrill to India. So that is also an augmented reality. What it does is verify the position of your jigs, essentially by superimposing an artificial image on top of the real bone. And the homegrown Arthro 3D, which is coming from Ahmedabad. So that is also using HoloLens. It can be a little difficult to adjust to this, and the robo might probably be easier. So that's my prediction. And then Gen AI, generative AI, as the word is, it generates content as compared to the predictive AI, what we were talking about till now. So generative AI, it was enabled by something called transformers, which managed to it made it possible to train extra large models without labeling all the data. So you have Chat GPT, DAL E for images, Gemini, Meta. They're all large language models. They ingest all the data that is there on the net. It does not mean that if you're using Chat GPT today, Chat GPT update as to now. It is update as to 1 year ago. It does not have the latest data. Only what data it has ingested, it has got. It then you have the GAN network, which has revolutionized medical imaging, generalized adversarial network. So there are two people, two programs working in tandem, not in tandem, but actually antagonistically. One generates an output, the other verifies the output and rejects the output if it is wrong. So they work together. So that is why it's called GAN. Problems are, of course, accuracy, bias, hallucinations, and it can be used in pretty much every sphere of orthopedics. Digital twins are statistical models which can use all of this data put together to create a model which represents that particular joint or the skeletal system, into which you can input a question and get an answer. So these are still something that is, we are working on a few digital twins of organs, but these are still far from reality. Some of our work is this thing, and the ethical aspects is what the title was all about. AI must be designed to assist humanity. It's not designed to go after it. It must be transparent. We have to know how it works. Men must know about machines. You have to know what you are using, why you are using it. Don't use it just like that. We must respect the dignity of people. You must let them know that a machine is making the diagnosis. It must be designed for privacy and responsibility, and it must avoid bias. You give it biased racial data, your algorithm will be racially biased. It's difficult to understand. Empathy is the most difficult aspect to replicate in a machine. That will be coming from you. Education, there is no way, but all of us have to get educated in this area: robotics, AI, everything. The NHS has already got a plan. It is published papers by Eric Topol, and they have a structured plan to educate their entire NHS on AI and robotics. Judgment and responsibility, you have to accept it. Any decision by a machine still means that a human is ultimately responsible. Thank you.